All right, thank you very much. So our agenda today, we're going to start with some introductions, and then we're going to look at just a high-level review of the pain and symptom management / palliative care workflow. I'm going to do a demonstration in Cerner, and then we have a few questions to ask of your Prince George team. Just starting with introductions, I've already introduced myself, but just in case anyone joined late, I'm Erin Dykstra. I'm a clinical informatics specialist with the CST team. I come from BC Cancer in Abbotsford. I'm a registered nurse there. Arlen, are you on the line? Can you introduce yourself?
Hi there, my name is Arlen Haywood. I am the Senior Leader for Clinical Informatics here at BC Cancer with the sort of on the implementation side of things.
Thank you, Arlen. And I've just got a call out here that we do have a lot of team members from the BC Cancer Sustainment team, as well as BC Cancer Implementation team and the CST project team. If anyone from these teams would like to introduce themselves out loud, please feel free at this time. And if not, please enter your name and a little bit of your background into the chat for our recording purposes.
Aaron, I think I'll jump in a couple of times in this session, so I will just quickly introduce myself. My name is Max Besworth. I'm the manager for provider engagement and adoption with CST, and we'll be working with the physicians and nurse practitioners in terms of training and go-live support, and worked a little bit with Pippa and her team in Vancouver. So nice to meet everybody.
Perfect. Christy, would you like to introduce yourself as well?
Sure, I can as well. My name is Christy Abrahams. I'm an informatics lead. I work with Max. So I will be working with you as well and look forward to doing so.
Thank you. Anyone else from those teams who would like to introduce themselves? Okay, hearing none. I'm hoping to just get a quick introduction from our SMEs or subject matter experts at Prince George. So first on the list there is Eunice. Are you on the line, Eunice? Okay, I don't see Eunice on the line. Dr. Reddy, would you like to introduce yourself?
Thank you. I'm Inbin Reddy. I'm one of the physicians that works in the pain and symptom clinic in Prince George, and I'm also the lead palliative care physician for Northern Health.
Great, thank you so much. Dustin, I see you're on the line.
Morning, my name is Dustin McKay. I'm one of the pain and symptom management nurses here in BC Cancer Prince George.
Thank you. Megan, I think I saw you join our group.
Yes, hello, I'm Megan. I'm the Senior Practice Lead for Nursing for BC Cancer Prince George. Just to note though on the slide, I am not fulfilling the clinical nurse educator role anymore, so just SPL. Thank you.
Thank you, Megan. Kieran.
Hi everyone, my name is Kieran Shoker. I'm a pharmacist here at BC Cancer. I was doing pain and symptom a few years back, took a break for a little while, and now I'm back on the roster of the pain and symptom pharmacists here at BC Cancer Prince George. Thank you.
Fantastic, thank you. Rochelle.
Rochelle Suchalotowski, Clerical Supervisor, Prince George.
Great. And I think I saw Dr. Holly join the call.
I'm muted. I'm muted now. Yes, I'm the head of the pain and symptom management palliative care team in Vancouver Centre, and I'm the provincial lead. I started the program 25 years ago now. So we have gone live with Cerner, as you're all aware. Hopefully I can be helpful in advising you guys about to go live.
Yes, excellent. Thanks so much for joining us today. I did have an invitation to your pain and symptom nurse from Vancouver, but I don't think I see them on the line.
Yeah, I know Zara's working today because I've had emails from her.
Okay.
But she's pretty busy, I think.
Okay. Are there any other subject matter experts from Vancouver Centre who would like to introduce themselves at this point? Okay. Thank you. I'm going to proceed with the presentation now. Our first slide here is talking about what is a subject matter expert. And I think most people on the line have heard this slide and this spiel already, so I'm not going to belabor it too much. You'll notice that we do start to call you SMEs. So SME, SME, short form for subject matter expert. And please do feel free to speak up and let us know if you've identified any gaps in these workflows as we go through them. If you have any questions or concerns, we do value your input very much. And you have been chosen by your organization to provide feedback, so please feel empowered to do so. The purpose of our session today is to provide you with an opportunity to view the enterprise workflow for pain and symptom management palliative care clinic. We're going to look for any gaps in relation to the Prince George clinics and validate as able. Just a quick CST overview. Again, I think most people on the call have seen this slide before. And just to remind everyone that we are looking at the CST Clinical and Systems Transformation Project, which is translating Cerner for the VPP, so Vancouver Coastal Health, Provincial Health Services Authority, and Providence Healthcare. We're really striving for patient safety as a priority, delivering care in the best way every day, FaceTime, not chase time, so we've got the charts available online rather than on paper. We can use the data from the electronic medical record to help improve patient care and delivery of services. And we do want to, of course, strengthen our core as a CST team to reduce clinical systems maintenance costs, for example, and improve the reliability and stability of the technical environment. Just a quick glance at some of the Cerner applications. Today we are going to be focused in PowerChart and the scheduling appointment book with a little stopover in PM Office as well. So all of these applications do work together to make up the patient record. Just some guiding principles. We are looking to make change where it's required. So we don't want to make change for the sake of change. We would make change, however, if there were safety implications, regulatory implications, significant financial implications, or if the content just does not exist in the system and is required. Our focus is on enterprise design. So I did allude to the VPP, the Vancouver, Providence, and Provincial Health Services organizations. And we do want to consider how changes we make might impact upon those other organizations. The priority is the must-haves, those things that must be completed prior to activation, as opposed to nice to have. But if those nice to haves are required after activation, then we look at quality improvement for those pieces. Any questions about these introductory slides? Okay. So just to try to set us up for what we're going to be viewing today, I've just given an example here of a scenario for an internal referral to the pain and symptom management palliative care clinic. So we're going to consider for today that we have a 75-year-old male who's been newly diagnosed with prostate cancer and has mets to the bone. They have uncontrolled pain. They're currently on fentanyl patch and morphine with minimal effect. And the BC Cancer PG provider is going to place a referral to pain and symptom management palliative care in Cerner. We are using Vancouver Centre locations today, just because all of our Prince George locations are not necessarily built yet. So this is a workflow overview of what the pain and symptom management palliative care clinic workflow looks like. So our first step here is actually, in fact, the provider placing the referral order, but then the clerk will receive that order, and we're going to show that in scheduling appointment book. This abbreviation is pronounced SHAPT book as far as I've ever been taught, that is. And we're going to review the referral and triage it as a provider. We're going to have the clerk schedule the appointment, contact the patient and confirm the details. And then on the day of the appointment, check the patient in. We'll touch on the nursing pieces of this workflow in that, in our understanding, nurses do the BPMH, the best possible medication history at Prince George. We'll have time for questions on that afterwards, but just currently that is the understanding. And then the nurse will complete their clinical assessment and documentation, and then turn over the patient to the provider to do their assessment and documentation. And then if there are any referrals or orders or prescriptions, those would be entered into the system. And then the clerk can book the follow-up appointments as required. Any questions about this workflow?
So what level of detail do you want at this point? Because there's multiple issues with all those boxes. I just don't know where to start, that's all.
Okay. Pippa, if you don't mind giving me an example of one of the issues, maybe, first of all.
Okay, so triaging, there's a thing called referral manager.
Yes.
Which the physician or nurse practitioner will be using to do this triaging of referrals. So there's no training module for that, as far as I'm aware. We did not get trained to use this. We were unaware of its existence when we went live with CST in Vancouver. No, and the clerks didn't know how to put the referrals into the referral manager for us. So we didn't get any referrals for the first 2 weeks until we thought there's something fishy going on here, and then realized that.
Fantastic feedback, yes.
So number one, the clerks need to be checking for referrals daily.
Yeah, I think it's a good point. And to be honest, Pippa, I think a lot of these tools were brand new for Vancouver Center. So now that we have the lived experience of how they're best used, some of the pieces to emphasize. I think what Erin will highlight today as we do the system demonstration, because I think we're going to get into the weeds today, is all of the different pieces relative to each of those steps. So I think, Erin, we could probably do the demo and Pippa throughout that conversation.
Yeah.
I think that's probably where some of these comments will make more contextual sense for else.
Yeah, let's go through it, and then we'll come back to figure out the details once everybody's seen the overview.
Okay. Yeah, thank you very much. That does sound great. So just bear with me while I switch over to PowerChart here as a provider. And that is the nurse. So we're going to go in as a provider. Confession time, I didn't actually open a radiation oncologist in PowerChart. So
sorry,
I do
Erin,
need to do that.
Do you mean palliative care?
Yeah, I'm actually just going to show the referral first, the internal referral. Yeah. Okay. So this will take just a moment.
Erin, just while you're doing that, I happen to have the reference text open, so I'll give you 30 seconds just to be able to do that, because I do want to have a quick conversation about the content of this. So Erin's going to jump into this afterwards, but just as a referring provider, just while she pulls it up, there is the ability to place referral orders in the system to be able to have a patient triaged by a particular clinic. So we will be demonstrating on the Vancouver Center. While Erin's pulling this up, I want to talk about the first window that pops up when you first refer into the Pain and Symptom Management Palliative Care Clinic. First of all, I want to give kudos to, I probably was Pippa who initially designed this, but it was taken into consideration in terms of the regional services and clinics across the province. So right now, this is called reference text. It's giving some information about how to place orders or send referrals to these clinics. And because Vancouver Center is live with Cerner, it does indicate, please place this order. And there's a telephone number to call with further questions. If we look at the section for Prince George, right now it says this is the phone and fax number for Prince George. I just want to validate potentially with Rochelle or someone else on the call, is this the fax number that's currently dedicated to the Prince George Pain and Symptom Management Clinic?
They do not have a dedicated fax. And I'm gonna just quickly check and see if I can find out what that fax number is, because I don't recognize it.
Okay, sounds good. Do you know which clinic it's shared with, Rochelle?
Well, it's the chart prep room. It could be general clinics, anywhere.
Okay, sounds
The
good.
nurses
So at
are
this point,
physically located right next door to the chart prep room, so they tend to use that one a lot. I don't know of anything that gets faxed in for pain and symptom though.
okay, perfect.
Nursing
So what
could
would
contribute.
happen is, as part of bringing Prince George online, is we would actually update this section of the table such that anybody who's in Cerner at either Vancouver Centre or Prince George would have further instructions to place this order. So we would be updating this reference text and can put a ticket to do that. Pippa, I guess I would ask you and the other providers on the call, the inclusion and exclusion criteria and waitlist timing. Is this indicative of provincial service? Is this more Vancouver-based? Do you think we need to revisit any of this text to make sure that it can be used across sites?
The wait list, I think, maybe substantially less for Prince George, because you've got the nurse practitioner Eunice, who's available outside of regular clinic time. And in Van, I know that you and Paul aren't always there, but Eunice is there. When Eunice isn't there, there would be a problem. But I think the wait list for patients is actually substantially less there.
Okay.
Yes, that is correct. I think at most 1 to 2 weeks.
Perfect. So on that note, just because this would be used provincially, would it be appropriate to sort of remove the 4+ weeks and leave the content to say, for urgent referrals, please also contact directly? Or how could we modify this text to be inclusive of the different centers, Pippa?
There are some things which have to stay different.
Okay.
I don't think we can provincially standardize that, because we need people to know that in Vancouver we can't see people. Like if they just put in a routine referral without information for us with the triaging, you know, we won't be able to see people that quickly. So people need to know that, but we don't want Invan and Eunice to be being phoned about every referral. Even if they're going to be able to see them in 1 or 2 weeks, which may be perfectly fine, there's no need for a phone call. So that's just a make work project. So this is something that cannot be standardized. I think that the provincial standard probably is to put a time for each center in that box there.
Yes, and what we can do that. So I think based on that information, we can update this reference text to include a little bit more site-specific information. I don't want to distract too much from the rest of the demo, but Aaron, what we can do is we can take this offline, come up with a bit of a table structure to be able to represent the unique requirements from each of the sites in this, such that they'll be able to share the order itself. But just wanted to have that quick conversation. And then Inben, we might reach out to you or someone from the clinic just to clarify the language and expected wait times that would be more conducive to the Prince George situation. So that's probably a follow-up that we can take away.
Thanks, I appreciate that. And you know, because wait times might change, just a thought, could it be a dynamic thing that the triaging provider could change it or update it as the wait times change? Because I'm sure it will vary from moment to moment.
So it's not as flexible as an individual provider being able to go in and make changes to this content, but we do have a process whereby any changes to the system, including scheduling slots or references, can be put in as a ticket, and there's a team that will be forever assigned to making some of these changes. So absolutely something that could be considered. And Aaron, I'll flip it back. Oh, sorry, go ahead. Oh.
Sorry, was that me?
Yeah, go ahead.
Yeah, at the very end, it says for appropriate referrals, please ensure prognosis and palliative drug benefit status are in the most recent note, and ensure you've completed the advanced care planning section of the patient chart, full stop. And then there's this, it's like a sentence that someone's added. I wouldn't have added that. I would take out unless also clearly documented in your note, because we don't want people to be thinking that because they've dictated important information and they've not put it where it's supposed to be, that's not okay. So could you please delete the last sentence of that section?
Absolutely. Yeah, we can take notes on that and we can remove it. It looks like a partial sentence as it is anyways.
Yeah, I think that's a typo somehow. I don't know where that came from.
Sounds good. Erin, I'll flip it back to you. I think you'll probably have it open to be able to place the order and then take us through the process.
Sounds good. Yeah, thank you very much. So I am logged into a patient's chart as a radiation oncologist right now, and I'm just going to show you the process for the referral. And we're going to see that reference text come up here in a minute that Max was referring to. So I'm not going to belabor this point. I'm just going to move on since we've seen it and go into this order. I'm going to modify the details of this order to include the reference text considerations. So when I open this up, and I hope you can see it clearly, yellow fields indicate sections that must be completed before we can sign the order. So we're going to indicate, first of all, a scheduling priority. We can choose the next available appointment, or if this is something that can wait that we would like to have, within a certain time frame, then we can make that selection as well. And the location right now, we only see Vancouver Center. And then the reason for referral is going to be for pain management, but this could get more specific, or it could be in the doctor's dictation. And then part of the reference text that Max was referring to is to indicate what treatments the patient has already tried and whether or not the family is aware of this referral. So sorry that this doesn't paste super clearly, just fix that. But the referring physician would be indicating here what treatments have already been tried, whether or not the family is aware of the referral, and any other special considerations which will help with the triage process. Any questions about this section? Okay, I'm going to sign this.
It's not intuitive because it says special instructions, but it's not special instructions. So people need to be told that in the special instructions box, that's where you put all the background information. You can't fit in the 250 characters under the reason for referral.
Yes, you bet. So it is indicated on that reference text that this must go into special instructions window.
Are we stuck with special instructions as a title, or is that, I've never seen any change to that, but
No, I think we are stuck with that in a sense because these order formats are pretty general. So yeah. I guess we could talk further in our conversations later about that reference text if there are other changes to be made. Okay. Just signing that order. So now that order has gone in and I'm going to enter the system as a clerk.
And Erin, just to be cognizant of time, I think Rochelle is our primary representative as a clerical supervisor, and the steps that we're about to show are agnostic and the same for all clinics. So I guess I would ask you, Rochelle, do you want us to demonstrate creating a referral encounter and doing the work that you've seen before, or should we move forward a little bit more?
I'm not quite sure what you meant by all clinics.
So any of the supportive care clinics, similar to what we showed in patient family counseling, these are really the same steps for by when a referral is sent, a referral encounter needs to get created for the purposes of referral triage. Just wanted to verify if you wanted to see that again. We're happy to show it to the group.
No need to repeat that.
Okay, so okay. I think Erin, we can show quickly creating the referral encounter, but just because the majority of the SMEs are clinicians on the call, if we have a referral encounter created, can probably move forward to referral triage just for the sake of time.
Yeah, so Max, are you suggesting maybe I just go in as the provider and go to referral management then?
I think so, yeah. There's no requirements we would need to gather. It's a pretty standard workflow, and we don't have specific clerical representation from the clinic here.
Yep, that sounds good to me. So just now I'm in as a provider, and do note that I don't think Eunice has joined us, but nurse practitioners are providers as well in the system. This kind of triage can also be done by a registered nurse, but for today's purposes, I'm logged in as a palliative care physician here. So you can see I've already, we're in referral management, and this is where new referrals would come in that are ready to be triaged. And I've already run this this inquiry before, so it's showing what I've already selected, but basically these selections will stick, as you can see, as the triaging provider. Once you choose these options, they will stay for you. So if you were not looking for those referrals ready for triage, you would select something else. The medical service is palliative medicine. I think there was conversation around whether it should be palliative medicine or pain medicine, but palliative medicine was chosen as the best option here. So I'm going to run.
Can I just interject
Yeah.
here? You need to tick the pain medicine one as well, because we still get tons coming in as pain.
Oh, okay.
So I think
Thank you.
that I looked in prod and it looks like they're using both, Erin. And the other thing I'll just comment on for the clinic, you have PHSA as the location here. So we do have the ability, we'll set these up so that they can be filtered down to just the BC Cancer Clinic for pain and symptom management as well.
Yes, great. Thank you for pointing that out. So you can see here now I've just drilled down and we can just choose Vancouver Center. So for our purposes today, I'm just going to actually borrow this patient here. Nope, that's a 10-year-old. We don't need to do that. So I will borrow this patient here, CST Build Test Pain and Symptom Management Clinic. Whenever we go into a patient's chart, the system asks us to assign a relationship so that we know why people are using the patient's chart. And today I am the triaging provider. So as the triaging provider, I'm reviewing the patient's chart, reviewing any documentation that I see from other physicians. So just opening up the documentation here, we have a few different notes on this patient. This is, of course, a test patient, so some of these things will not be applicable to your patients, but this is where you would review documentation on the patient to consider the triaging priority. Just a quick question for Prince George. Do you ever decline a patient?
Sometimes, yes, if it's the inappropriate referral or the family physician hasn't initiated in basic steps in managing the pain, we may have a discussion or refer the patient back to the family physician.
Okay.
And in rare events, we've had patients who had chronic pain issues and had already seen a pain specialist, and they were just sending them to us for another opinion. And when we reviewed the chart, it wasn't an appropriate referral.
Right. Okay.
Yeah, we've had similar ones in Ban, but also some of them are too sick, and they should be being referred direct to the home hospice program, not to an ambulatory clinic, and that should be in the reference text that I think we saw earlier. So they could be too sick or not appropriate.
Okay, so additional considerations there then. Just showing another quick example. Well, I don't think we need to actually belabor this too much more. I'm going to go to the referral triage page here and actually accept this order. So I'm going to new order entry, pretend for me that we have investigated this patient and have determined that they are appropriate for the pain and symptom clinic. And so I can put in this accept referral order.
And there are multiple ways you can do this in Ban. You can also use the outpatient quick orders. I don't use that orders function. I use the different one, which is going through on. If you go, we'll wait till she's finished doing this, and I'll show you where I do it. I use the quick orders function.
Do that, and so you go to outpatient quick orders.
I click on that one. And then you can personalize this, and you can go where you need to go more quickly, because you can change the position of them and the colors of them on your own screen. So you don't have to wade through all the irrelevant stuff to get to where you need to go.
Yeah, it's nice. There's a lot of personalization that can be done, and we'll be covering that, of course, in your training sessions as well. So basically, I've just accepted the referral, and that indicates to the clerk that this referral has been accepted, and they will go ahead at that point and schedule that patient for an appointment. In the interest of time, and because we're not really reviewing a lot of clerical workflow today, I'm going to now skip ahead to the clinic visit day. You'll see me switch to a different patient here as well. And I'm just going to make sure I'm logged in as a registered nurse. Oh, sorry, lost my window. Okay, so now I am logged into this, the power chart as a registered nurse, and I'm going to choose this patient for today, PG Demo Melbeck. Just opening up the patient's chart. Once again, I need to assign a relationship, and then I can go into the patient's chart. So I guess it's Dustin today, right? Thanks for joining us, Dustin. And I can see Eunice has joined as well now. Thank you for joining this call. I'm just going to quickly show some of the assessments that are able to be done in PowerChart. So first one being going to the interactive view in I&O. This is where physical assessments can be documented, vital signs, weights, heights, other things. Not going to look too deeply into this because I would like to get to another component here, which I'm just scanning for. So in this ad hoc folder, I can choose different forms that can be documented on. And for the pain and symptom clinic, we can actually choose this adult pain and symptom management palliative care form. There's also the opportunity to do the oncology comprehensive intake, which is akin to the PRISM form, which I don't believe you would be doing in this clinic. Sorry, I'm just reviewing my notes here, and I think I have accessed this the wrong way. So I'm just going to go back to my ambulatory summary here and go to this advanced care planning and goals of care section of the chart. So you can see here in this section, we have advanced care planning documentation. If there were any in the chart, we'd be able to see that pull through here. If there was a code status entered, then we could see that here. And if I hover over it, it shows me what the patient's code status is. Goals of care as well would be present here. I have indicated previously that this patient is a non-curative intent patient. And if there was any MAID documentation, we could see that. There's a drop down here to actually select the relevant power forms for your clinic related to advanced care planning. So if you were doing advanced care planning today, then you could choose these power forms in order to do that.
Can I just clarify that in order to get the code status into the banner bar up the top there, you have to write it as a medical order. So you have to go into outpatient quick orders and write it as a medical order. Just putting it in the advanced care planning documentation or goals of care section doesn't get it in there. The resuscitation status order function doesn't work.
Right, it does have to be in order, that's correct, in order to get into the chart, into the banner bar. So I've just gone ahead and opened up the power form now for an adult pain and symptom management palliative care assessment. And we can see there are multiple options here. And I'm just going to expand this for the moment so that we can read them a little bit more clearly. Once again, if there are required fields, those are indicated in yellow. So you cannot sign this documentation unless you enter a dosing weight. Then just quickly going through some of these other tabs. Here's some one pain assessment tool. I think we would mostly be using ESAS in the pain and symptom clinic. So we can go here to document the ESAS, a self-reported pain scale as well. I guess really the localization of which tabs and how you choose to use this form would be a discussion within your group at Prince George. So I'm not going to go too much into more detail here. But just to note that this is where additional assessments can be completed.
Can I just say, at the moment, we don't use any of this section, Emban. We only use the POSI pink form, the old pink form system. So and we don't have a nurse to do this anyway. So none of this is done. I don't even know how to look at it in Cerner.
Right. Okay. So you still use the pink form, the patient completes it. And is it scanned into Cerner at all then, Pippa?
It's done electronically now, but not all centers are using the electronic versions yet. And it's still very hokey because we don't have the clerks trained or able to do the emailing out. So at the moment, our pharmacist does the emailing out to the patients so that they can do the electronic pink form before their appointment. And with their own, often the patients can't, we get about half of them. A lot of the times the patients can't do it or won't do it.
Okay, right. And pardon me, you did of course say that that's via POSI. So I know Prince George does have access to POSI as well. So we might have to look into how to get that working for the pain and symptom clinic as well.
Yeah, this is just this is a generic thing. That's they just basically thrown all the pain and palliative stuff into one big place, a big bucket, and there's no direction to the nurses as to which of these they should be using. So as I say, we don't have any nurses anyway, so we just don't do it. We just completely bypass it, and it's a waste. It would be nice if it could be improved so that it was actually useful.
Right, so that if it was more tailored to the current pink form, it would probably make more sense.
Yeah.
Okay. At this point, I'm just going to flip over to a provider view now. Are there any questions as I do that in relation to the nursing functionality in PowerChart?
Could you just go back? There's an important function there that I think might, for the personalization, about changing the order of the gray column.
Oh, for nursing or for provider?
View.
You
go
bet.
Back to the provider view. For the little house.
So this is our provider view.
Yeah, click on the little house there. We're in quick orders right now. We don't want to be there. Go back to the little house. Click on the little house at the top. There you are. Go click.
Pippa, are you looking for your outpatient chart, your documentation?
Yeah.
There we go.
Oh, there we go. Okay. Yeah. So see this row on the left that's in gray under transfer/discharge.
Yes.
Okay. So if you just drag those titles, you can move them where you want.
Yeah.
So
and
I always start with documentation, and then you can do current medications. So all the stuff about transfusions and all that stuff, you don't need any of that. So just leave it at the bottom.
Yeah, for sure. There's a lot of personalization again that can be done in the system, and it makes it a lot easier to navigate the chart.
Yeah. So you just drag them up, and you can make it much easier to navigate that using that gray one. I find the gray one much better than the blue one. There's some stuff you have to go to the blue one, basically just Care Connect, and some stuff for orders. But most of it you can get in the gray one, which is actually much smaller, so you can fit it on one screen. Whereas with the blue one, it goes down too far and there's too much crap you have to fish out around to find what you want. Whereas with the gray one, it's a lot more easy to hone in on what you want.
Yeah, and that's kind of how these have been created too, is so that you can navigate the chart more easily within these, what we call M pages. And then, well, these are the M pages, and then these are the components within. So you can organize these. As you can see, I'm dragging and dropping elsewhere as needed. Just going to draw a little bit of attention to the home medications piece. And now Eunice and Dustin are both on the line. And we also have our pharmacist, Kieran. At Prince George Center, who does the best possible medication history currently?
Nursing usually completes it on the phone before they come in.
Okay, thank you. So that's for every pain and symptom patient coming in?
No, that is not always the case. Sometimes I will need to do it when the patient comes. It may have been done by nursing, but that's not consistently the case.
I guess the point being that either way, it can be done within the chart here. And I'm just going to go to the meds history and just point out that when we're in a live system, the medication history can be imported from PharmaNet. So much like you probably print a PharmaNet in current state, you would just import it here. This patient has some medications that have been ordered, so it's kind of nice to be able to see those. And right now what I'm doing is just acknowledging that I've checked with the patient, done their BPMH, and I'm going to document that history. And now that I've completed that, whether I was the nurse doing that, a nurse practitioner, pharmacist, this allows the, now the provider can go in and do the medication reconciliation. So whatever your usual practice is here, as far as which medications you might say for the patient to continue, or if there are any that you might say the patient should discontinue, then you can indicate those here.
And can I just ask, Pippa, is this something you're doing? We see some clinics using this more than others. It's technically not from a system perspective mandatory, but usually the health authorities have some recommendations on when it should be done. Are you using this tool in the Vancouver clinic?
We mostly use it for doing prescriptions, and I do try to do it, but I clean it up. Basically, it's such a mess a lot of the time that you have to, there's just yards and yards of irrelevant stuff, like duplicates and triplicates and quadruplicates and like of orders, because the oncologists refuse to use it properly. They just keep entering new orders, and they don't delete the old ones, so you don't know what the patient's on anymore. And I don't know whether they like to keep that as a record of when they started something or not, but there's always too much stuff on there, and it also doesn't, this is a bit that drags into the letter. It auto imports. So if you don't do this, then you have to clean it up when you're editing your dictation. If you do clean it up, you still have to edit the dictation to an extent. So this is a kind of a luxury. If you have time, you do it. But a lot of the time we're not able to update information about drugs that we are not prescribing.
Yeah, I was just going to say one of the key pieces that's different. Yeah, Erin, you can talk about this quickly and then we can move forward.
Sure. So just to point out what Pippa had mentioned about prescriptions, so you could indicate in this column whether it's a prescription you're writing based on that medication. And then to her last point, acknowledging remaining home meds. So what this does is essentially acknowledges everything else that I haven't necessarily indicated, and then I can sign this with the detail.
You end up having to sign for stuff, Rainband, that you actually don't know is true. You have to confirm that you've clarified something without having that information. It's the only way to make it work. You can't move to the next section unless you tick yes to that, even though you have no idea.
So this is definitely something in the training we can spend some time on, Erin, just in terms of the use of it, but we can probably jump forward to follow up in other orders.
Sounds good. Thank you. The last thing I'm really going to show before we have a little bit more conversation time is just the creation of your documentation. So you can see at the bottom of the M page, the outpatient chart M page here, are some note types. And when I select these note types, it'll open up in a template for me, and I can document within any relevant sections. Anything that's already present in the chart, you can see has pulled into its relevant sections. So here we have our problem list, medications, allergies, a social history. Anything that you don't want to go into your dictation at the end, you would just indicate that by removing it, clicking this X here. And then of course your assessment and plan would follow in here. During the teaching, then our educators will be showing you how to tag notes and bring those things into your documentation as well. That's beyond the scope of this session, but that is an option as well if there's other relevant information in the chart that you want to have pull into your dictation. Your dictations can be signed or entered using speech recognition software. So I'm just going to not really document anything here, but just show you how to sign this document. So when we do go to sign, Max, do you want me to touch on relationships again?
We can just quickly mention it. Yeah, just the lifetime provider. So whoever the primary care physician is, as well as the referring provider, very similar to most EMRs, will receive an automated copy of that note. And you'll also see the lifetime oncology provider as well. If they have a primary oncologist, they'll show in this window.
Okay, perfect. And I'm just going to sign and then show where that is available after. So we can see that outpatient consult note is now available for viewing in the documentation section of the chart. So
we're working on a new version of the template, Enban, because the template is not personalized for us. So we're working with the CST team to improve that. There is a free text version. You saw there was 2 consult note templates there. One was the one that auto imports stuff and comes up with all the pre-specified headings, but there's also a free text one. But there's a cheat you can do to insert your own template where you do comma something. You can set the code for what you want your template to be. But what we're hoping is that we'll have sorted all this out by the time you go live, so that the template that comes up automatically will suit your needs as well. Because the one that's in there at the moment doesn't really meet our needs.
We use Cerner for Northern Health, and we do our consults directly into the chart, and we have our own templates for those.
Yeah.
And we use speech recognition to do it. So we just tab and auto populate as we go along. So we'll have a look at those templates as well.
Yeah, they'll probably be pretty much the same by the time we finished.
Sounds good. And sorry, Erin, can you just, I just know that a big focus of work with the Vancouver Centre Clinic, if you could just pop into the outpatient quick orders quickly.
Yeah.
So there is both a follow-up order. So if you need to see the patient back in the clinic, there's the ability to place a follow-up. But Pippa, I know you've worked for years on all of the infusion plans. And I just want to clarify with InVan, I know that these are typically done in the PACU at Vancouver Centre. So things like high dose lidocaine. InVan, do you order infusions for your patients at Prince George?
We haven't done them in the pain and symptom clinic at BC Cancer. We've usually done it in ambulatory care at UHNBC.
Perfect.
So,
okay.
And that's to do, I think, Pippa, you can correct me, I think it's with the timing of how long the patient needs to be monitored, and we didn't have the nursing staff to be able to do it at BC Cancer. So we ended up doing it as an outpatient at UHNBC, but that's where we would do our infusions and so on.
Okay, that's very helpful. Thank you, Inman.
Yeah, perfect. Anything else before I navigate away from PowerChart?
There's a lot of usage things here, but in terms of the orders, if you just scroll up, if you're looking for an order, you can actually type it into that box there. Yeah, and code status. It only works when you're in certain views. So if you type, you've got code status there, that it's working in that, but sometimes it doesn't work. And it's usually because of the encounter type. So if you go code status and it doesn't pop up, if you go up to the top right, where underneath where it says location, where it says encounter type referrals, we admit. So you need to click on that and find another encounter type, which allows you to enter that. It's a glitch in the system, I guess, that it doesn't allow you to access it in certain encounters.
I wonder what.
Does it have to be your encounter that you access it through, or can it be, say, the oncologist encounter?
I don't know. I've not ever looked at that. I just try and pick on any physician access one. It might be whether inpatients or outpatients. I'm not sure. I'm not sure which ones allow and which ones don't.
Max, do you know why that would be?
Yeah, I can quickly comment. So it doesn't have to do with the location. I think what you're running into, Pippa, is in the new order entry box, this green box that you're searching the orders into. Typically the orders catalog, so the types of orders that you can access are defaulted by the outpatient versus outpatient prescriptions. So there's a little toggle right above that helps you sort of flip different order catalogs. And typically when you can't find something, it's usually because what you're looking for is more considered sort of an order that's attached to that registration versus a prescription. But we can take that as a follow-up. I'm happy to look into that. And Pippi, I can reach out to you with the solution for that one, because it should be as simple as just flipping that little toggle there.
Thank you.
Yeah, it is not. It's something to do with the encounters. I do the flipping back for the prescriptions thing, and I think you can get into it from both of those little outpatient prescriptions or outpatient. I think you can still get into code status from that. There's something weird about the encounters that that stops it from working.
Okay, let me take a look.
But it rarely happens now because I know about it, and so I just make sure I double check the encounter is correct before I go in. But if you're new to it and you don't realize that that's an issue, you just get blocked.
Okay, sounds good. Sorry, back to you, Erin. I think we have a couple questions from the Prince George folks.
Yeah, do we have questions? Sorry, I'm actually just going to navigate to the PowerPoint. There we are. And these are questions that we have for your team in Prince George. Some of them I think we can go through hopefully pretty quickly. We're running short on time. Just wondering, who generally refers patients to pain and symptom? Are they all internal referrals, or are some from external?
Yeah, we get quite a few externals, and those are a bit of a ragbag of mechanisms. So essentially what we do is we kind of collect them all from however they come in, whether it's by email, use of a 10-year-old referral form that somebody found in the bottom of a drawer, or a phone call. So we create an internal referral essentially on behalf of the referrer.
Okay, is that applicable to Prince George as well? Or
yeah, that's true. We have had internal and external referrals, and sometimes we just get an order written, sometimes we get a form, sometimes we get an email.
okay, and you do accept external referrals, so patients who are not being seen by a BC Cancer provider?
Yeah.
There's some discussion about whether we were supposed to. We certainly have in the past, although that hasn't come up recently.
Yeah, no,
Okay.
if you're a cancer patient, you should have access to services. Whether somebody's having current treatment or not is really not relevant. A lot of patients would not be having palliative chemotherapy or deciding not to have radiotherapy, but they still should be able to access all the supportive care services.
Yes,
So,
and I should rephrase my question. It's really not so much that they're currently seeing an oncologist, but have been referred to BC Cancer in the past.
Yeah.
Okay.
The BC Cancer website has an external referral form on it, bccancer.bc.ca. So any physician or nurse practitioner could refer from anywhere without having to be in the system. They can just go onto the website.
Okay, and again, as long as that patient is a cancer patient, whether currently seeing an oncologist or finished with treatment.
Correct.
Okay, wonderful.
Eunice, I was just going to say that in the past, we have seen hematology patients who are not technically BC Cancer patients. They are managed by hematologists from VGH or somewhere else. They don't have a BC Cancer number, but they do get treatment at BC Cancer, like through the con clinics or whatever. And so we've had this kind of oddball patient that has turned up for us a couple of times.
Okay, if they're referred to the well, I'll take that away and contemplate that further if there are any implications to the referral workflow.
Yeah.
So do you ever, I think we covered this a little bit already, but do you ever turn patients away, and how is that communicated to the referring provider or referrer?
So you're asking
for Prince George. Sorry, for Prince George.
So yeah, I do turn patients down. Usually I wind up having to phone the patient anyway to like discuss their their circumstances.
Okay.
I always wind up having to chart on them anyway. Depending on how they were referred, I will either phone or email the person that referred them and just explain the situation. Like sometimes we'll decline the referral Sometimes there'll be chronic non-cancer pain and not really appropriate for us. Like there's lots of different reasons. Sometimes they may only be taking Tylenol and I send them to their family doctor.
Yes. Okay, that makes sense. Are there any additional phone calls that are scheduled in connection with the pain and symptom clinic? So I'm thinking probably more implications for the registered nursing team. So Dustin, you're on the line. Do you get scheduled, do you need to make scheduled phone calls?
Yes, frequently. Almost after every Wednesday clinic, there's usually a follow-up phone call scheduled for the Friday. And then if there is, we'll do a follow-up call on the Monday prior to the clinic too for a reminder appointment and check-in. And these are all booked by the nursing team as well. We don't usually have clerical support.
Yes. Okay. You anticipated my follow-up there. Thank you. Okay.
And Erin, I'm
do
just seeing we're close to time. Just from just one quick question I want to ask Pippa while she's here. Pippa, are you using, so there's something called message center pools, which are shared inboxes in Cerner for the providers and the nursing staff. Are you using those in Vancouver Centre, and do you find them helpful?
The only one we use it really, the only thing we use it for is when we're informed that somebody's in hospital.
Yeah.
Because we have a lot of problems with access to Care Connect. They won't allow our care aide to have access to Care Connect, and she's the one that's supposed to be making the phone calls before the appointments to make sure that people are actually going to show up. And often they don't, and it's because she hasn't got hold of them. It's because they're either dead or in hospital, and she's not allowed to check Care Connect, which is stupid.
Okay, so, and you do have a separate pool right now for the providers as well as the, there's a nursing pool, or do you not use the one? You mentioned you didn't have a nurse.
Well, we have one nurse for all of the 6 physicians, so she doesn't really fulfill any nursing duties in the clinic. She's doing all the out of clinic work.
Okay.
So yeah, no, we don't use that pool function really, as I say, other than just information about for people coming in from outside, like home care nurses that are phoned in. That we ask people to message all of us because we all need to know who's in hospital.
Sounds great. Thank you very much.
Sorry, I was muted there. I think I know the answer to this question, but do you routinely administer medications in pain and symptom at Prince George?
Not routinely, but sometimes.
Yeah. Do you sometimes trial like a maybe sufentanil or like buccal or something like that? Or
That would be really rare. If somebody came to the clinic and was in a pain crisis, we have administered medications, not sufentanil so much, but certainly we've done sub-Q hydromorphone or POs hydromorphone on just a couple of occasions.
okay, so it's very, very rare.
I'm
And
not
then
use sufentanil potentially, but hopefully that wouldn't be necessary.
yeah, hopefully they're not in that much pain.
Yeah, we've been through this in Vancouver with what's in the Omnicell, and they took out all our short-acting opioids from the clinic. So that's a real pain as well. So you might want to see if that's fixable before you start. Make sure you look at their list because someone else is making decisions about what you need, and I don't know how the decision got made, but it is a real pain when you can't access the short-acting opioid quickly. We have to send somebody up to our inpatient unit, but you don't have an inpatient unit to go poach
Yeah.
from. So you need to have, this needs to be different.
Okay. Definitely, we'll take that away as well. Are there any labs or point of care tests completed in the pain and symptom clinic at Prince George?
We might order labs, but we don't necessarily.
Okay, yeah.
You wouldn't draw them there.
You often need to take urines. I mean, our clinics function in the same way. If you have somebody with the potential acute UTI, you have to get urine right there and then. It's helpful to have the ability to take the urine tests. That's pretty much all we do.
Okay. So Eunice or Dustin, would you be sending urine for CNS after dip sticking, or would yeah, just wondering how often that might happen.
It would be very rare. I maybe can think of one occasion that we've needed to do that. The other thing we maybe have done on 1 or 2 occasions is do a blood glucometer.
Okay. Okay.
Oh, yeah. Yeah, definitely need to have that in as well. And random urine drug screening. Again, we rarely do it, but you need to be able to do it on occasions for drugs.
I think we have dealt with all of the questions that we need to. And so I guess just in
just you know, in terms of investigation, right?
I'm so sorry, the first part cut out for me.
Sorry, I said we might also be ordering imaging.
Yes, okay. And that's, yeah, that's definitely, we can order that in system and have a requisition printed for patients to take over to the diagnostic imaging department.
I don't think we're on paper anymore now with the diagnostic imaging. That's all done on the computer now.
But Prince George's, because their diagnostics would be done at UMBC. So they would
Oh,
place the
see, so
order, but then need the
you're
paper.
sticking.
Yeah.
Our clerks do the booking for imaging, and because we don't have clerical support, it's a bit of a gray area about how those bookings take place. Because I think typically the nurses are not faxing the requisitions to radiology. I'm getting somebody from clerical to do it, but they aren't always happy to be doing that because they're not supposed to need to help us.
Okay, so are all of your diagnostic imaging appointments scheduled by the clerks at BC Cancer?
Sorry, I probably misphrased that. The clerks send the requisitions to the hospital. People do not themselves, and then usually the hospital calls the patient if it's a non-urgent, but if it is urgent, our clerks will often, like if you have to send somebody because you think they have a PE, the clerks will wind up having to call over and book them a same-day appointment or a next-day appointment.
Okay, that's good information too. Does anyone else on my CST team have any questions before we close the session?
You need to have a workflow for rejection of referrals. Just make sure that that's sorted, because just saying reject referrals in Cerner is not enough. You can't just reject it and then, because then you get an endless stream of phone calls and complaints from referrers. You have to close the loop with them. I don't know how you would do it. It would presumably involve Eunice, but it has to be a clinician that does that, because there's usually a very good reason why you've rejected it, but the person who's referred will be mightily miffed at having their referral rejected. So you have to justify it to them and give them another alternative plan.
Okay. That's great. Any other feedback, questions?
For the external referrals coming in, you need a process, a pathway for the clerks to convert that into an internal referral so that it can be put into the referral manager. That's important because they do come in all sorts of strange ways, and there needs to be a process there.
Okay. Okay, so we'll investigate that further then.
In terms of gaps. Yeah.
I guess all things considered at this point, do we see any gaps in the enterprise workflow for BC Cancer Prince George, or do we feel like we're able to answer that question today?
Can you put the workflow thing back up again?
Yeah.
A lot of this is going to require clerks. So
yes.
you have to make sure that every one of those arrows basically is a clerk has to do something. And we've had incredible difficulties. We've just been assigned somebody who's going to be working just with us, which is, we haven't really had time to get used to that yet. She only just started. but it would be really helpful to have very clear definition of who is the clerk that's going to do all these things, and they have to do it every day.
Yeah, I think
A proper job.
that is a big conversation.
Or is there an alternative in the workflow? Because in some of these places, this would be being done by a nurse, and in some places it would be done by a provider.
Yeah, no, then they won't let the nurses or the doctors get into any scheduling because it's so complicated. You have to have a huge training program to figure out how to do simple scheduling tasks in Cerner. It's a nightmare. You don't want to do it, Eunice, please, and Yemban, you don't want to have responsibility for doing it. I had a look at it, it's a nightmare.
Hi, this is Rochelle from PG. Now that I'm seeing some of what may be needed, I have already earmarked potential reduction of work for the chart prep clerk, increase of work to support pain and symptom management. I just need more information about what chart prep is going to look at before I solidify any decisions of that workflow.
Probably should talk to the clerks at Station D at BC Cancer Vancouver. Just give them a call and see and just chat with them like clerk to clerk. It would be good to have some idea of what their estimate is for amount of time that they have to spend with each patient and how long it takes them to process an order.
I'm sorry, Pippa, can you repeat that name, or are you able to type it into our chat window?
No, I don't know, it changes quite frequently.
Okay.
Amisha Naidu, let me just type in here. Amisha.
All right.
Is probably the one that's been there the longest. She's I mean, it's just been a revolving door. We've had multiple clerks in and out. They all look the same, unfortunately. At one point we had Amisha and Manisha and somebody else that sounded just the same as well. They all were beautiful with same brown hair and blonde, big brown eyes, and they were all the same accents and everything. They were indistinguishable. It was really difficult. But if you just phone Station D, it's local 2756, and just ask to speak to whichever person picks up the phone, they'll tell you who to speak to.
Sounds great. Thank you. Okay. Apologies for going over time. Is there a desire to talk any further about any of the content of this meeting right now? And otherwise, just knowing that we do have follow-up meetings scheduled, and I am trying to find the date for that, but it's in a couple of weeks, I do believe, in February.
Can I ask a quick question about the training modules? Have they been updated since we did them? Or are you getting the same package we got?
It's Christy. All of that is currently under review with the learning team as far as what's relevant and what fits best. And then Max and I are working on content for the in-person workflow reviews as well.
Okay, because I'd be happy to help advise on what would be useful, because what we got was not particularly useful, and it was a lot of time. It was 8 hours for each person. So if we're going to be spending 8 hours, that's a major time commitment for busy clinicians. I mean, Eunice and Imban and Paul, they don't have time to spend 8 hours doing something which is not particularly helpful. So we need to make sure that it's like there's some of it that's helpful. Probably about an hour of it was helpful, but if we're going to use their time effectively, we need to make sure that the training program is very substantially revised to be helpful.
Thank you.
Okay, I've come up with the date that's penciled in. I don't know that it's a firm date yet, but at this point we have February 13 on the calendar from 1 till 3. But we will be following up with each of you with regards to setting that date. Okay, are there any closing comments or questions? Okay, I'd like to thank everybody for your time. Thank you so much for attending the session today, for your feedback. It's very valuable to our process and is incredibly helpful towards building a system that will be working for you. So thanks so much for your feedback. Appreciate it very much. And I look forward to continuing to work with you. Have a great day. Bye-bye.